Hey everybody, it's Heather Vernillo, and I just want to go over with you guys what's going on this week. You're going to be doing chapters 6, 7, and 8 in your Clark book. Learning outcomes for chapter 6 is going to be analyzing the interrelationships among economic conditions, healthcare systems, and health status. We're going to go over factors contributing to the escalating healthcare costs. We're going to discuss the effects of economic factors on the provision of public health, analyze the effects of selected healthcare reimbursement mechanisms, and you're going to be able to distinguish among selected approaches to financing healthcare services. Make sure you go over your key terms that are in the front of chapter 6. So defining economics, the way in which a society distributes its resources to address human wants and needs. We got two major aspects to this: the interrelationships between economics and health, and the financing of healthcare services. This is an important thing to think about when we start discussing patients who have to choose between their insulin and being able to pay their electric bill, and why some patients will ration their insulin, end up in a diabetic ketoacidosis, and be put in the hospital. Because a lot of times as nurses, we have preconceived biases and we'll say, I can't believe this person's not taking their insulin. And we need to look at the economic relationship between the healthcare and what's going on inside their home. There's three fundamental economic principles. Resources are always more limited than what is needed. Resources have alternative uses. Different people will have differing ideas of how resources should be used. And we need to make sure that we are advocating for our patients. Community needs assessment conducted by collaborative of community agencies and residents and coordinated by a population health nurse indicated that low salaries were a significant influence on the health status of a community. After additional data gathering, the members of the collaborative initiated a campaign to promote living wage for a large segment of the population. As a result of their efforts, a living wage ordinance was passed by the city. The ordinance required payment of a livable wage approximately 3 times the minimum wage level of the state to all city employees. In addition, all businesses that contracted with the city were required to guarantee the same living wage to their employees before submitting bids for government contracts. Although the ordinance did not cover the entire population, it provided an adequate income for a large proportion of its city's residents. So that shows you a role that a community health or a population health nurse can play in her community or his community. So 3 fundamental economic principles must be considered in examining the effects of economic conditions on health and healthcare services. And the first principle is the resources always are more limited than the desired levels of consumption. Resources have alternative uses, and different people will have differing ideas as to who should be able to use the resources. And based upon these principles, the basic question related to healthcare economics is how limited resources should be used and what type of health services should consume the resources that are available. So relationships and economics, social productivity and stability, healthcare spending, socioeconomic factors, and health status. So social productivity and stability. As we noted earlier, we often think of the effects of economic factors on health status. What we tend to forget, however, is that health also affects the nation's economic welfare. A healthy population is more productive than an unhealthy one, and being better able to learn and use education effectively to increase society's overall productivity. When people are unable to work due to health deficiencies, society loses their productive capabilities. So diseases leading to disability result in lost productivity for those affected, and family members must leave work to care for those sick family members also. So poverty and ill health leads to lower income and slowed economic growth, as well as a society that is unstable and has conflict. Conversely, nations with strong economies are better able to afford healthcare and other determinants of health status. Economic factors influence availability of and access to healthcare services, which affects the health status of individuals. And my bird is going to scream because she loves to do that when I'm talking. She's trying to participate in the PowerPoint. Societal productivity and stability are affected by a nation's overall health status. Populations affected by chronic illness and general illness, they cost society lost productivity and decreased revenue. So let's talk about healthcare spending. The amount of money spent on healthcare services in the United States has been increasing at an alarming rate over the last decade. For example, national personal healthcare expenditures increased from $27.3 billion back in 1960 to almost $2.5 trillion in 2009. Okay, so that's almost 15 years old. So we already know that it's probably well over 4 or 5 trillion by now. Healthcare spending is expected to continue to grow by an average of 6.2% per year. And that is based on numbers coming from the Centers for Medicare and Medicaid Services. So overall, healthcare spending has risen from 5% of what's the gross domestic product, our GDP, in 1960 to 17.2% in 2012, and is expected to rise to 19.9% by 2022. So US per capita expenditures for healthcare in 2012 was about $8,000 a person. And this per capita expenditure reflects the average amount spent on healthcare per person per year. So factors that influence healthcare costs, we got aging population, greater use of technology, emphasis on costly specialty care, cost of care for uninsured, and the cost shifting, and of course, US drug prices. So uncompensated care leads to what's called cost shifting, and it's the passing of the cost of an uncompensated care from those who cannot pay to those who can pay. So cost shifting leads in turn to higher insurance premiums and higher overall costs for healthcare. And then further things about uncompensated care is that a proportion of the care in which the provider receives no reimbursement. So things like charity care and just patients who refuse to pay. So a large segment of the population is uninsured, or they're underinsured, or they're stuck with a catastrophic Obamacare plan because it's the only thing that they can afford. And then a large amount of the uncompensated care gets provided by healthcare institutions and providers, and approximately 3/4 of uncompensated care is provided by federal, state, and local agencies. Healthcare spending differs for different elements of the healthcare system. For example, if you look in your book in figure 6.1, I believe it's on page 147 if we have the same book. It's indicated in 6.1 that an estimated 28% of healthcare dollars was spent on hospital care, 43% was on physician and clinical services, 5% was on dental, 7% was on nursing home, 4% was home health, and 13% was prescription drugs. Oh, never mind. Next slide had the exact thing that I was just talking about. So 2012 expenditures was about 2.3 trillion. So that's what, 13 years ago? So it's probably about 10% higher. Socioeconomics, we're looking at malnutrition, poor housing, lack of healthcare, lack of adequate childcare associated with low literacy levels, and that limits someone's earning power and their access to healthcare. We are looking at health and neighborhood socioeconomic statuses. Numerous recent research studies have demonstrated the links between socioeconomic status of one's neighborhood and the variety of adverse health effects Okay, so this is going to tie into the question for this week's discussion board about looking at your own population, your own local neighborhood. What is, in your opinion, the healthcare problem that a community health or population health nurse could go in and try to do education? Is it obesity? Is it lack of access to food? Is it that you have to drive everywhere, that there's no ability to just walk to a store and get your dinner and pick up fruits and vegetables, that you always have to be able to get in a car, so not everybody has a car? Is there a public transit system available in your local neighborhood that can help people get to the things that they need? Do the obesity there, it is, if everybody does drive, nobody's walking, are there parks? Like, these are things I want you guys to start thinking about as far as community health, is basically the health of your community. Like, population health nurses are able to help individual clients and families deal with economic issues. They cannot address the issue of low socioeconomic status by themselves, but they can at least go in and we do like what's called a windshield survey, and we look at the neighborhoods and we address all the needs, because everything kind of ties back into health, because mental health also kind of plays a role in this too. If the sidewalks are not repaired, if the homes are, not repaired, if there's potholes and there's other things, these all lead to somebody's homeostasis or their well-being. So think about things that you might do to promote improvements in the status for low-income neighborhoods that are in your community. Another issue is lack of health insurance. Most common among young to middle-aged adults. A lot of them feel they don't need it because they are quote unquote healthy. We also have to look at job loss and losing health coverage and age. A lot of times employers now cut hours to just be under the threshold of having to offer employer-based benefits. Whether or not someone's eligible, maybe their spouse held the health insurance and then their spouse died, or perhaps you were a stay-at-home mom and you got divorced and your husband is the one who carried the health insurance for you. So there's a lot of factors at play when it comes to someone's lack of health insurance. Poverty affects one's ability to gain access to the necessities of life that support health and wellness, including food, shelter, access to healthcare. And poverty is measured in terms of one's income relative to the current federal or state income guidelines. So this does change state to state. So when we have this lack of health insurance, we are going to be associated with a variety of health effects. We're not doing preventative screenings. We are not having someone who is compliant with their medication, and we are decreasing access to care. Instead of having a primary care model or preventative care model, we end up with a tertiary care model where a person has a cut that needs to be addressed, but they don't have insurance or they're underinsured, so they don't go to the doctor for it. And then it gets infected, and then that turns into cellulitis, and it starts to travel up their leg. And now we have someone who goes and presents in the ER with 103 fever, with white blood cell counts through the roof, who is going into sepsis because they had an untreated cut that should have had maybe a round of antibiotics and been fine. But now we have someone who's going to be in the tertiary care model, racking up an extremely high bill for something that could have been prevented had they had seen the doctor in the first place. So this is all where we talk about like disparities and why community health nursing is so important. The second major way in which economic factors affect health is through diminished access to needed healthcare services. Diminished access occurs as a result of the mixed effects of poverty and the lack of healthcare insurance. 38% of uninsured people are below the poverty level. And during 2011, 48 million non-elderly people in the United States were uninsured. It was a decrease from 2010, But lack of insurance is not confined to those who literally live in poverty. 32% of people with incomes that were well above the federal poverty level were uninsured. And more than 1/5 of those that are almost 400% above poverty level also were without health insurance. People who remain uninsured for a year or more are 7 times more likely to forgo needed health care due to costs. And there's a 4-fold likelihood of foregoing or delaying care. And the likelihood of going without needed care is twice as high for uninsured persons with disabilities as it is for those who do not have a disability. So we're looking at access to healthcare. We want better health status. We want a regular source of care. We want more appropriate use of healthcare services. Personal and societal consequences. We have unmet health needs. Remember back from your fundamentals, learning about Maslow's hierarchy, that still comes into play here. We have a delay in receiving needed care. We have an inability to obtain preventative services. We need women to be going for their mammograms. We need people to be going for their colonoscopies. We need everyone to be getting their yearly skin checks for skin cancer before these things become tertiary. And before a woman gets told she has stage 4 breast cancer because she hadn't had a mammogram in 5 years. We increased hospitalizations that might have been prevented, like the guy with the cut on the foot who now has cellulitis. So focused assessment, looking at a population. This could be a population looking at like maybe the city of Miami. You could be looking at a population, the state of Florida. You could be looking at a population of the Southeast United States. So it really, every time you do population focused health, you have to it doesn't have to be a small population. You can have very large populations. So you look at the average income of the group. What proportion of the group has incomes at or below the poverty level? What subpopulations are included in that low income group? What proportion of the low income families receive public assistance, and are those eligible for assistance actually receiving it? Because remember, to get public assistance, you need to have ID, you need to have papers, you need to be a citizen. So a lot of people don't have IDs. So we need to look at, why are you not receiving your assistance? Is there a reason? What can we do to help you get it? What is the level of unemployment in the population? And for those who are employed, what are the salaries? Are we looking at an area with multi-million-dollar homes and then a boat in everyone's backyard? Or are we looking at some of our lower socioeconomic, quote unquote ghettos, where the houses are dilapidated, the cars are 20 years old, and people are having issues with keeping the power on because they don't have enough money to pay the utility bills? What proportion of the population receives employment-based health insurance benefits? And why do others not receive benefits? Can they not afford it? Are they only part-time employed? Is it an area where there's a lot of migratory population where foreign workers come in to do day labor and then, head back, finish out their assignment and head back to their home country? How are most healthcare services for the population funded? Do you have people who have employer-based coverage? Do you have a large population who are on Medicaid? Do you have a large population who are on Medicare? What revenue sources fund that public health population? And are those revenues adequate to provide the needed services? And some mechanisms for compensating healthcare providers. We're looking at retrospective reimbursements, prospective reimbursements, capitation, and pay for performance. And all of those are defined in your book. Capitation is a particular type of a prospective reimbursement in which the provider or the healthcare system is paid by a set fee for a determined health service for each client enrolled in the health plan. So it's like a third-party payer, like an insurance company, pays providers on the basis of the number of persons enrolled in the plan who select that particular provider. All right, so that it's not a fee for service. It's not like I saw you and I billed you for an office visit. This is a payment that goes for all of, it's like a capped payment. Like Medicaid does this a lot where you have to take on like 150 Medicaid patients, and then you're kind of paid a set fee per month for each of those clients, whether you see them or not. We have prospective reimbursement is payment at a predetermined fixed rate for a specific healthcare program or set of services. And the rates are based on the extent of the resources typically used in providing said treatment. So prospective payments minimize the provider to render unneeded services because they're paid per incident rather than based on the number of services. So you go in for an office visit, but then the doctor does 4 other things. He's still only going to get paid that one fee, regardless of what he did. Pay for performance reimbursement is a newer approach for paying for healthcare services in which providers and healthcare institutions receive bonus payments for achieving specific quality outcomes. This one is a hard one because I am a provider, I am a nurse practitioner. So if I have patients who I'm treating for high cholesterol, diabetes, obesity, cardiovascular disease, things that are modifiable and treatable, and the person doesn't take their medication on time, they don't do anything to change their cholesterol levels, they're not checking their blood sugars, they're eating lots of foods they're not supposed to be eating, and their blood sugar and their A1C is out of control, the doctor actually ends up getting dinged for that and gets less reimbursement. So this is, to me, it's a vicious cycle because then providers don't want to take on patients who are non-compliant. And now they're going to end up bouncing these clients to whoever will take them. And this is not good healthcare, in my opinion. We need to treat every client the same. And we have to understand that not every client is going to be compliant. They're not going to always listen to you. They're going to still do what they want. So a pay for performance is not necessarily a very good thing, but I understand their point of wanting and urging providers to do more education so that their clients are having better outcomes. Payment for services rendered based on the cost of the service. Cost is determined after the fact. Forms of retrospective reimbursement include a fee for service payment and a discounted fee for service payment. Those are in your book. Fee for service is exactly what it sounds like. You come in, I see you, I send a bill to the insurance company, they pay it. Most are at a predetermined fixed rate. I already know if I bill code 99213, I'm going to get $77.52. Like it's a set thing. It doesn't matter how complex or non-complex or whatever diagnosis I did, doesn't matter how much teaching I did. That is the set fee. That is what I will get back from the insurance company. All right, so pay for performance is what we just talked about. It's a new approach. Providers and healthcare institutions will receive bonuses for achieving specific quality outcomes. So SREs, reportable events, they were developed by the National Quality Forum, and it's errors caused by care management, not from underlying disease, and errors that occur from failure to follow standard care. And the current list has 28 events in 6 different categories. Sometimes you'll hear these called as sentinel events. There's a lot of different wording depending on basically when your healthcare provider you're talking to went through nursing school, because we use different terms based on when we went to school. And then your book actually goes over all the different managed care organizations. I think it's on page 154. So that's something you might want to take a look at. Okay, so I lost my train of thought about where I was going with all this. All right, so healthcare funding sources, personal payments, commercial insurance. There's different types of commercial insurance. You have self-funded insurance, government-funded care, and there's also charity care. So personal payment, you pay the provider directly out of your pocket. This is used by very wealthy people who go to fancy concierge doctors. We have the uninsured who have to pay directly out of their pocket. And then we have out-of-pocket spending when we have insurance plans that have premiums that need to be paid, deductibles, and co-insurance. So if coinsurance is 20% and your doctor's bill is 100, you're going to have to come up with $20 on top of if you already have a deductible, and then that whole $100 went to the deductible, and then you owe that directly out of your pocket. Individual insurance is purchased by an individual directly from an insurance company. So these are like your self-insured or your gig workers. They have limited coverage usually, and it's for people who are not eligible for other insurance coverages. Pre-existing condition clause right now does not exist in the United States. But all that means is there could be a change of who our president is and whoever the healthcare HHS worker is assigned, and then they decide they're going to bring pre-existing conditions back into play again. But as of right now, it's been pretty much removed for the last like 15 years. Employer-based plans, popular because it's purchased with pre-tax dollars. So that actually lowers your tax liability and the amount of money that Uncle Sam gets from you. The disadvantages is that significant segments of the population are not eligible, and the premiums are going up, even though it's an employer-sponsored plan and they're bringing all of their employees to this plan. The premiums are just sometimes getting astronomical, and it's taking up sometimes a third of someone's paycheck. All right, self-funded insurance avoids third parties that increase the premium costs. Costs are based on the level of a pooled risk. It avoids the premium tax, and it's exempt from state insurance regulations. I see this one more with religious-based groups. They'll have a self-funded insurance plan. It has very minimum benefits that commercial plans don't, and provides tailored health benefits packages. There's health insurance exchanges. Enacted in 2010, each state is required to establish some form of a health insurance exchange. They permit individuals and small businesses to shop for affordable healthcare coverage, and there's different tiers: bronze, silver, gold, platinum. If anybody's ever logged on to, depending on which state you guys are from, I know a lot of you are from California, but if you're in Florida, we have the tiered plans that are on healthcare.gov, and then states like New Jersey, actually you don't use healthcare.gov, you actually have to use another New Jersey website, and they offer different plans, but they still fall underneath of the healthcare.gov umbrella. All right, so highlights: requirements for state insurance exchanges, provides web-based access, operates toll-free hotline, assistance screening and enrolling eligible people, using standardized enrollment, informing customers of satisfaction and quality ratings of the different insurance plans. This is all in your book that you can read. Government-funded care is the cost of care is borne by the government and by your taxpayers. Two major programs, Medicare and Medicaid. Medicare Part A is your hospitalization coverage. It's for care in a skilled nursing facility. It provides some home health care. It pays for hospice, and it pays for blood that's administered in the hospital. Medicare Part B coverage is your patient care. This is to pay for your providers. This pays outpatient care, some of your home health care, some services that were not covered under A, and it gives you a variety of preventative health coverages. Medicare beneficiaries, that's what someone who gets Medicare is called. They're a Medicare beneficiary. They agree to allow the service provider to bill Medicare directly for services, and service provider agrees to accept Medicare without billing a client for difference. So whatever Medicare says the doctor's going to get paid, that's what the doctor has to accept if they have Medicare in their office. If providers do not accept the assignment, the greatest amount that the beneficiary can be charged for a Medicare-approved service is 15% above the Medicare-approved amount for that service. So if I don't take Medicare in my office, but you are a Medicare recipient or a Medicare beneficiary, and I charge $80 for something, but Medicare says I'm only going to pay $25, I'm only allowed to bill that person 15% above that $25 that Medicare says they would pay for that same service. We have things called a Medigap, and it's they're little supplemental plans that beneficiaries can purchase to help cover the gaps between Medicare A and B. And there's also Medicare D, which is the drug plan. Now, Medicaid is a means tested program. So eligibility for services is based on one's income, and it's all state funded. Where Medicare is federal, Medicaid is ran by each state. The state programs provide a minimum set of federally defined benefits and can provide additional benefits based on state approval. So what Medicaid is in Idaho is not going to be the same as Medicaid that's in Washington state. The Medicaid program was established in 1965 to provide healthcare services to a segment of the population who could not otherwise afford care. Its original purpose was to integrate the indigent into the mainstream health care services. So Medicaid and the Children's Health Insurance Program, it's called CHIP, provides services for more than 60 million people in the United States, including 31 million children, 11 million non-elderly low-income parents, caretakers, pregnant women, and then other adults, and 8.8 million people with disabilities. So a lot of people could be eligible for Medicaid. We have, in Florida, we have pregnancy Medicaid. So the minute you find out you're pregnant, if you don't have insurance, you can apply. It doesn't even really matter on your income because it's a sliding scale. And every child in the state of Florida must have insurance. And if you do not have your own insurance, you get put into the state Medicaid program automatically. It does not really matter what your income is because the kid care goes off of a sliding scale. So Medicare, Medicaid, it's the funding source. Medicare comes from Social Security contributions. It's federally ran. Medicaid comes from the tax revenues, and it's state ran. For Medicare, it's disabled and elderly. And for Medicaid, it's your medically indigent. Benefits vary state to state. For your Medicaid, for Medicare, it's set hospitalization, primary care, prescription drugs, preventative. It does not provide for dental. Right, so your CHIP, your state Children's Health Insurance Program, provides health insurance needs for low-income children and pregnant women who do not meet the income eligibility requirements for regular Medicaid. State administered, but funded jointly by federal and state. Care that is provided, so charity care is care that is provided free of charge to individuals who meet the established financial criteria that was never expected to generate revenue. There's no reliable estimate of the amount of charity care provided in the United States, but I do know at the facilities that I've worked at, it was a pretty astronomical amount of people who receive charity care. So health insurance and reform, we have the Patient Protection and Affordable Act, ACA. A lot of people just call it Obamacare. Institutes a variety of reforms to health insurance and programs to improve the health of the United States population. So we have different provisions: mandatory coverage, employer requirements, expansion of public programs, cost sharing, subsidies, tax changes, and health insurance exchanges. We go through all those. Individual United States citizens and its legal residents will be required to have health insurance that meets the minimum requirements, or they have to pay a tax penalty for not having health care coverage. Although I believe that was overturned about 2 years ago or 3 years ago. I don't think you pay a penalty anymore. Employers with 50 or more employees will be required to provide healthcare coverage for their employees, or they have to pay a fee of $2,000 per full-time employee. The law also provides for expansion of Medicaid eligibility to all non-Medicare eligible individuals with incomes that go up to 133% of the federal poverty level. ACA also changes the threshold for including unreimbursed healthcare expenses as a tax deduction. Provides for creation of an essential health insurance benefits package. One of the changes with ACA was that you didn't get kicked off your parents' insurance at 18. You're now allowed to keep your children on your plan until 26 years old. It prohibits lifetime limits on coverage and withdrawal of coverage, except in the case of fraud. And it requires justification for premium increases. It prohibits denial of coverage due to presence of pre-existing conditions. Doesn't matter what you had, because it doesn't make you ineligible, and it doesn't mean you have to pay more for your insurance because you have a pre-existing condition. All right, so ACA includes a variety of provisions that will influence the health of the population by giving preventative health services and eliminating cost sharing requirements. Establishment of prevention and public health fund supports prevention and public health initiatives. We're looking at research, screening, and intervention activities. HR 3590 directs the Secretary of HHS to support a planning and implementation of a public-private partnership and campaigns to promote public awareness and education related to health promotion and prevention. We also want to support school-based health centers. A lot of children, their only access to medical care is care that is given to them by their school nurse. And it provides community transformation grants for community initiatives to prevent chronic disease and the sequelae of chronic disease. And we're looking at addressing our health disparities. We want to develop a stronger evidence base for preventative activities. We provide grants to develop and educate promotion and prevention programs. And that is it for Chapter 6. To do a recap, economic conditions have both direct and indirect effects on a population's health. Direct effects stem from the funding allocated to healthcare services. Indirect affects the reflectability of members of the population to obtain the resources needed for good health, meaning they can get appropriate housing, they could have good nutrition, as well as be able to afford their healthcare services. The cost of providing healthcare services in the United States has increased dramatically in the last few decades without appreciable increase in the population's health status. So it's costing more to treat healthcare patients, but nobody's actually getting better. Some of the factors involved in the increase include our aging population, our greater use of technology, emphasis on costly specialty care, cost of care for the uninsured, and labor-intensive nature of healthcare delivery. Failure to engage in health promotion and illness prevention activities has also increased the cost of healthcare where problems occur. And funding for healthcare services in the United States derives from several sources, and they include their personal payment, commercial health insurance, government services, government-funded insurance, and charity care. Approaches to reimbursement for healthcare services include retrospective payments, prospective payments, pay for performance. Population health nurses need to be conversant with healthcare service funding mechanisms to assist our clients to obtain their needed services. They can also campaign for allocation of sufficient funding for healthcare, particularly to cover the uninsured elements of the population, and develop and test cost-effective interventions to meet population health needs. There is a case study at the end of your chapter if you would like to look at it. Main questions that come out of the case study is what factors are influencing the health status of this migrant group? How would you finance the health care for this migrant group? And would fee-for-service care or managed care arrangements be the most appropriate for this migrant population? And then support your answer. Then you have your references at the end of the chapter if you want to do any further reading. And like that, Chapter 6 is completed.